Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of this show, I'm continuing to talk about rheumatoid arthritis. Rheumatoid arthritis is a very common medical problem. Across the world, 140 million people suffer from rheumatoid arthritis. In this country, you have about 2.5 million people there about suffer from rheumatoid arthritis. It's a very common problem. It's very debilitating. It's an autoimmune problem, meaning that the body reacts against itself, and that creates this rheumatoid arthritis affecting the different joints. And of course, one thing to remember, it is also a systemic disease, meaning that it affects all different organs in the body at one time or another, and to one degree or another. Before I continue, however, I want to share with you this new book that I just wrote, The Best of Medical Oncology and Clinical Hematology. This book just came out. It covers cancer of all types in the 21st century, also blood diseases of all types in the 21st century. Get your hand on it. I just put an ebook version of it on Kindle Direct, Amazon Kindle Direct, so that people across the world can get access to it. This is now done. You could just click on Amazon Kindle. You could get the ebook version. I wanted the world to actually have access to this book. I'm not in the book selling, money-making business. My main interest is to make contribution to the world so that I can help as many people as I can, so they can have a full understanding about the different diseases that I talk about. In this case, this is medical oncology and clinical hematology. Get your hands on it, and then hopefully you like it. Now, I said that rheumatoid arthritis affects all organs. It is systemic disease. Yes, it is. We talk about the joint part of it that is mostly affected, but it also affects the skin, the brain, the eyes, the heart, the lungs, the GI tract, the nervous system, etc., even the endocrine system. Because the rheumatoid arthritis may not just be rheumatoid arthritis. There are other autoimmune diseases that may get affected along with the rheumatoid arthritis, when the rheumatoid arthritis is the first disease that the person get involved with. And then the next thing you know, there are other things. So that when you have rheumatoid arthritis, there are many other rheumatological diseases that you got to think about, as well as other autoimmune diseases you have to think about that has nothing to do with joint pain, etc. That's called overlap syndrome, as well as mixed connective tissue diseases. That is why once you have one rheumatological disease, you must check for others that may evolve eventually as the person lives along the way. So it is mainly joints that are affected. It's called severe deformity of the joints, severe pain, severe tenderness, swelling, severe muscle problem, muscle weakness can be affected with it, etc. So last week when I left off, I was in the process of evaluating a patient. The patient had already been examined. You do a complete physical examination of the patient. And then now you were about to do blood tests and X-ray tests. The most common blood tests, of course, I'll review them for you again, will be a complete blood count, a complete blood chemistry profile. Then you will do an ANA, very important. You will do a saturation, very important. You do a fibrinogen level, super important. Then, of course, in addition to these things, you're going to also do a urine analysis. You will do a rheumatoid factor, crucial, because for you to have rheumatoid arthritis, to be qualified as such, rheumatoid factor must be positive. So now that you've done these tests, those are the basic as far as blood tests and urine tests is concerned. It's also very important to do a T4 TSH. You say, well, how do you go from rheumatoid arthritis to doing a T4 TSH? Well, you do a T4 TSH, an anti-thyroglobulin antibody, because there's a condition called Hashimoto's thyroiditis, which can be involved in somebody with rheumatoid arthritis as a secondary autoimmune disease. That's correct. And you don't want to miss that, especially when the person presents with symptoms that may be consistent with some thyroid problem. All these things you have to think. Clinical medicine is not something to just a very narrow. It's a very wide field. Multiple diseases can be affecting the person at the same time. You do a total CPK. Well, why would you want to do a total CPK when you're dealing with rheumatoid arthritis? Well, the person may have polymyopathy, weakness to the muscle, polymyositis, inflammation of the muscle. The CPK will pick that up for you. Very important. So once the CPK is elevated, then you're forced to find out why the CPK is elevated. You also go ahead and do yourself an LDH. Very important to do an LDH. Why are you doing an LDH? We're doing an LDH because you want to make sure that this individual who has rheumatoid arthritis is not also afflicted with some other diseases such as a hemolytic disease, hemolytic anemia. If you can't have hemolytic anemia without having an elevated LDH. You do a reticulocyte count because you cannot have hemolytic anemia without having an elevated reticulocyte count. You have to do all that. You can't because unfortunately it would have been easier if each disease would present by itself as a mono disease, one disease. It doesn't work like that. Because if you don't keep those things in mind, you're going to miss all these other diseases that may be even more serious than the rheumatoid arthritis itself. That's correct. It will be much more serious than the rheumatoid arthritis itself. But if you just rheumatoid arthritis and you stay right there, then you got yourself in trouble. Rheumatology is a beautiful field, beautiful subspecialty of medicine. If you need help, go and see a rheumatologist. Me, as a professor and somebody who teaches general internal medicine, I have to teach rheumatology as well as practicing it. So therefore, it doesn't always happen like that. So not everybody isn't at the level that I am, where they're also practicing, they're also teaching. So there are rheumatologists out there that will help you. They are fantastic physicians. That's what they do for a living 24/7. So if you have issues, you think that it's complicated, get yourself a rheumatology consultation. These people know this stuff inside out. So now that you've done all the blood tests that I mentioned, why is the serum ferritin so important, as I mentioned before? Well, the ferritin is important because it's going to be elevated. It's going to be elevated because rheumatoid arthritis is an inflammatory disease. Any chronic inflammatory disease that you have, no matter which one it is going to cause your serum ferritin to become elevated. Absolutely. Become elevated because the inflammation itself is preventing the transferrin receptor from grabbing the iron to take it to the bone marrow because the inflammation blocks that. So the level of transferrin receptor in the blood is going to be very high. You can in fact measure it. It's clinically available to be measured. You could do that. It's going to be very high because it has nothing to do with just floating around with no work to do. So therefore, because of that, the ferritin is going to be extremely high. How is that important? This is very, very important because the rheumatological problem, namely the rheumatoid arthritis itself, is damaging the joints, damaging the liver, damaging the spleen, doing all this stuff to the different organs. But guess what? The second problem is the fact that the inflammation that the rheumatoid arthritis is causing is also causing iron to be piled up in the body. So that's a secondary problem, secondary hemochromatosis because of the inflammation. That is now a second thing that's damaging those organs as well. Because wherever the iron is sitting, the joint, the heart, the liver, the spleen, wherever, that's also going to degrade. Iron cannot sit in the body without degrading. The body is going to do the best it can to try to get rid of it. Can't, but it's going to try. As the degrading process begins, that process is going to cause free radical to be released. And the free radical then begins the process of inflammation that's going to further damage the organs in question. Doesn't matter what organs they are. You can't have iron piling up in your body without the iron itself causing the problem. Everybody who's suffering from major hematological diseases such as hemolytic anemia of one kind or another, all these people subsequently suffer tremendously from the piled-up of the iron. That is why we have chelating agent that we use to try to chelate the iron so we could let the person urinate it out. Unfortunately, most of these individuals also are anemic because you can't have a chronic inflammatory process in your body that's permanently there without you developing anemia. That's anemia of inflammatory diseases. That's correct. So therefore, the person is too anemic to be phlebotomized, to remove blood from them so that you remove the iron. Each unit of blood you remove from someone has 250 milligrams of iron in it. That would be fine. But unfortunately, the person is too anemic for you to do so. That is correct. Therefore, it is complicated. Let me tell you something. This is much more complicated than you can possibly imagine. People die who have rheumatoid arthritis, not from the rheumatoid arthritis itself, but secondary association with heart failure, pulmonary failure. They become fibrotic. The lung fail. A lot of people die from the lung fail because they have rheumatoid arthritis. So you have to be constantly on the lookout. You can't just say, well, here's rheumatoid arthritis. The rheumatoid factor is elevated. The surrogate is elevated. Here's some medication. That's not the end of the story. The story is much more complicated than that. So now that you've done this blood test, what else are you going to do? Well, you're going to start to do X-ray. Originally, you're going to do plain X-rays to see if there are degenerative changes in those X-rays. But that's not good enough. Absolutely not good enough, because the joints themselves, the ligament themselves, cannot be seen just by the plain X-ray. So you have to wind up doing MRI. You have to do MRI. And the MRI will tell you. And sometimes these things happen spontaneously. Wherever the joint is that's hurting, wherever the organ is that's hurting, you must do an MRI of that organ to get the full picture of what is really going on. Failure to do so will be not, of course, providing high quality care. And then once you find a joint that is degenerating, that has severe ligamental problem, that are either torn apart, then this is the time to call the orthopedic doctor. Yes, orthopedic doctor for help, because the patient's joint may need to be replaced or dealt with surgically in one fashion or another. And the orthopedic doctors are there for that. They are flat out fantastic surgeons. That's what they do for a living. Okay? So now that you get your X-ray done, you've done all your blood tests, and now suddenly one of the X-rays show, oh, by the way, one of the blood tests that you must do a serum uric acid as well, because you could be full. You could be full. The pain in the joint may not necessarily be to rheumatoid arthritis. It may in fact be to gout, or the gout in association with in association with the rheumatoid arthritis. I mentioned LDH earlier. The LDH is not just good to help you with somebody who is hemolyzing, because you have ways of telling somebody is hemolyzing or not. Even though you got to be very careful, super careful. Because if the person's liver is good, don't expect the indirect serum bilirubin to become elevated. You might miss it. Let me give you a little formula to put in your pocket. An indirect bilirubin up to 4.5 can be handled by the liver. So when you look at the total bilirubin, you look at the indirect bilirubin is high when someone is hemolyzing. But if the liver is normal, functioning normally, up to I shouldn't be telling you these things, but I'm telling that to you anyway, and I hope you pay close attention. And indirect bilirubin up to 4.5 can be taken care of by the liver. So when you are looking at the liver function test, take a look at the alkaline phosphatase. Take a look at all other LFTs to make sure they are normal or abnormal. Because if the liver is bad, the liver is very damaged, the liver function test will be abnormal. Right away, that tells you that you would have expected the indirect bilirubin to be truly high. But if your LFTs are normal, meaning that the liver function tests are normal, up to an indirect bilirubin of 4.5, that liver can handle it. So you can't go there. That's not going to help you. Okay? That's not going to help you. You have to keep this. Remember, I told you before, for every lock that ever existed, be it the old-fashioned lock or the modern fancy lock, has a code or a key. You cannot practice high-quality clinical medicine without knowing some of these keys and know what to do with them. Things are so expensive these days, so super expensive. The tests are expensive. The doctor's visits in most instances are expensive. The co-pays are expensive. Some people cannot afford them. But if you have a smart doctor who understands these things, one test can eliminate the need to do a whole bunch of other things, with the doctor being fairly certain, absolutely, completely, totally certain that cannot be. So therefore, why waste the time and the money to do it? How are you going to be hemolyzing, having normal LDH? That's not going to happen. How are you going to have a lymphoproliferative disease, such as cancer of the lymphatic system, and have a normal LDH? That's going to happen. So therefore, if your LDH come back normal, then you know right away you don't have to waste the time spending all that money to chase things that don't exist. You can eliminate several dozen diseases by just one test, but you better make sure that you know that concept, because all lymphoproliferative associated cancers, all of them, no matter the name, no matter the type, will cause the LDH to be up, because all these cancers, as I said last week, multiply and grow via the anaerobic pathway. Anaerobic means without air, without oxygen. And the end product of the anaerobic pathway is lactic dehydrogenase / LDH. That's it. That's your answer. So why are you chasing all these things around when you have a normal LDH? Because they cannot be. You see the key right there? You see, you just opened the lock. You just opened the lock. I have no idea who taught people these things, who are teaching people these things. I went to one of the best medical schools without bragging, Albert Einstein College of Medicine. I trained at one of the best training programs in this country, Montefiore Hospital Medical Center. And I had fantastic teaching. And yet, 80% to 90% of what I do every single day in the practice of medicine, I taught myself. Nothing negative about my medical school. Nothing negative about my training program. They were just flat out fantastic. They still are. But I am telling you, 80 to 90% of what I do every single day, what I write every single day, I taught myself. See, Principal Val, where do you have time? Somebody told me the other day to write this book. I said, well, that is what I do. I don't play tennis. I don't play golf. There's nothing wrong with tennis or golf. I don't belong to any fancy social club that you have to pay $25,000 a year to be a member. My job, my profession is clinical medicine. That's what I teach. My hobby, if you could something this serious, you could turn it into a hobby. That's what I do. That's my hobby. My hobby and my profession. That's what God put me on this earth for. I had no idea how I came into this earth, but I found out quickly that it was to practice medicine and teach medicine. I figured that out. So therefore, then you have to know these things. There are brilliant doctors out there. If you don't know this stuff, for the sake of the patient, for the sake of being ethical, please refer the patient to someone that knows best to help the patient. Because this is a responsibility that you assume to help this patient. You are the advocate for the patient. You have that responsibility. Every week, I spend hours fighting. Last week, I spent 3 hours one day. Another day, I was on the phone from 9:30 in the morning, from 9:30 a.m. until 1 p.m. fighting on behalf of a patient whose life has been saved by what I did, and now the insurance company figure out some many years later they want me to change the medication for this patient to try something new that is generic, when what I've done is presently saving the patient's life. I say I will not do that. I don't care what you say, or you could do whatever you want. I will not do that because it's not ethical, it's not professional, and it's not legal. I absolutely refuse to do it. Why would I want to do that? Where is the guarantee that the new medication is going to be tolerated by the patient and it's going to be any good to begin with? Forget about it. I will not do it. I couldn't care less what you say. I will not do it. So that's a fight. It's not a small fight. It's an all-out war. And guess who won it? I did, because I will not give in. So therefore, then you have got to, and believe me, my colleagues do. This is not unique. Doctors, they have bigger office. They have people to help them across the country. Billions of dollars worth of time that physicians have wasted every year fighting on behalf of patients. Billions of dollars worth of time have been calculated by the AMA. So I'm not unique. I'm not special. All my colleagues are fighting. It's a non-stop 24-hour-a-day fighting for them to save money as opposed to me to save somebody's life. My job, my responsibility is to save my patient's life. I am a human being. I'm not perfect, but folks have not even given me a chance to do something illegal myself. They're constantly after me for professional and personal destruction for one reason only, because I fight on behalf of my patient. Never had a chance to fight for myself yet. And they've done everything under the gods. If they tell you there's one thing that they have not done in the city of White Plains to destroy Dr. Alcena, they're lying. They've done it all. They just fail. And they continue to fail. Because what I'm doing is what God wants me to do, to practice quality medical care and fight for my... Once I say yes to a patient, it's a yes. And I'm not doing this TV show looking for patients. Don't even bother to call my office. I have not taken new patients except for people that work with me in the hospital or some family members of my colleagues in almost 10 years. I'm not interested. Okay? Don't even bother to call, because I cannot talk to you on the phone about anything because you're not my patient. Just enjoy the show. But this is who I am. I don't have to apologize to anybody. I've been in this world on my own since I was 7 years old. Nobody told me how to survive when I was 7 years old. How dare anybody to try to tell me how to behave and how to survive now? They don't have an IQ that is as high as mine, and they don't have achievement medically, professionally, that's as high as mine. Some of them don't even know 1/3 of what I know. How are they going to tell me what to do? So in any event, rheumatoid arthritis, serious problem, serious disease itself, not the overlap, not the chronic collagen diseases that are combined, but the disease itself is bad. It affects the joint. The joint may have a lot of effusion acutely. You could see that on the plain X-ray. What you going to do with it? Well, before you even provide other treatment for the patient, And last week, of course, next week I'm going to start talking about treatment. You must tap that joint. If you don't know how to tap it, the ER doctor can tap it. You have to call an orthopedic doctor to tap it. Then you must know what to do with the fluid that you're going to take out. What's the characteristics of the fluid? How does it look? Is it cloudy? Is it yellow? Is it bloody? Or a combination thereof. Then once you get your hand on that fluid, what do you do with it? Well, part of it has to go to the microbiology lab for two tests, for gram stain and for culture. The gram stain with the right away, you could stain it, let it dry, look at it under the microscope. If there's bacteria in there, right away you could tell if it's a gram stain, gram negative, coccyte, or rod. You could tell. So right away you could call the ER and say there's bacteria on the slide. So right away the doctor knows there's an infection there. Then you're culturing it. That's going to take 72 hours to come back. You send it to the chemistry lab. What are you going to do with the chemistry lab? Well, you're going to check the protein. You're going to check the sugar. You're going to check for LDH. You're going to do those three things in the chemistry lab. If there's an infection, the sugar and the fluid will be low, the protein will be high, the LDH will be high. If there is no infection, the protein will be high, the glucose will be normal, the LDH will be high. Then you take it and send it to the hematology lab. What are you looking for? You're looking for total cell, total white cell, total red cell under the microscope. You're also looking for crystal. What type of crystal? If it is a gout, there's going to be different type of crystal. If there's no crystal, therefore it can't be gout. It is due to the arthritic process itself that's causing the fluid. Right away you did two things. Number one, you remove a whole syringe full of it. That gives the patient relief. And now you know, having done all this stuff, that you're not dealing with an infection. An infection, you must act immediately, otherwise within 72 hours the joint will be destroyed. You can't afford to miss that diagnosis. If it's just the arthritis that's causing it, then right away you know you're going to give the patient steroid. Sometimes you inject the steroid right in there. The orthopedic will do that with some pain medication, some anesthetic, and so on and so forth. And then of course you're going to provide Endocin, which is acutely the strongest NSAID we have to manage the process until you make other decisions. Listen, I'm going to stop here. Next week, we're going to continue to talk about rheumatoid arthritis and how to actually treat it with medication, etc. Until such time, keep watching the show. Dr. Alcena saying so long and bye-bye.